It is something that I found people are struggling with. The strong ones who don't acknowledge their emotions, who wear that mask of productivity. No one knows they're struggling. We all have emotional traumas. We may not have a trauma that the DSM-5 designates as a trauma, but we all have emotional experiences, painful psychological experiences that shape us and changes the way that we view ourselves in the world and the way that we interact in the world. Everyone has mental health. We may not all have a mental health condition, but we all have mental health the way that we have physical health, and we have to nurture it. We have to take care of it so that we don't develop a mental health condition.
Anxiety and depression and so many other mental health disorders are on the rise. We know that we have a crisis when it comes to mental health in this country and honestly across the globe. I felt like it was really important to dive more deeply into the conversations around mental health, and that's why my next guest is going to help us with this issue. Let me introduce you to Dr. Judith Joseph. She's the author of the highly anticipated book on high-functioning depression. Dr. Judith is a board-certified psychiatrist and chair of the Women in Medicine Initiative for Columbia University College of Physicians and Surgeons. She's a clinical assistant professor of child and adolescent psychiatry at NYU Langone Medical Center. She has conducted several clinical research studies in pediatric, adult, geriatric, and women's mental health as the principal investigator in her own research lab. She recently received a 2023 congressional proclamation from the U.S. House of Representatives for her social media advocacy and research in mental health. In May of 2024, she lectured at the White House for the Executive Office of the President of the United States and taught members of the administration a workshop on how to improve their mental health. She's been an expert on various media platforms, made a number of national television appearances, and received her education from Duke University, Columbia University, and then Columbia Business School. Please join me in welcoming Dr. Judith Joseph to the show. Welcome, Dr. Judith. I'm so glad to have you on the show.
Thank you for having me. I'm excited to be here.
This is a really important topic at a really critical time. I mean, I think I sort of repeat what everybody already knows when I say that we have a mental health crisis. It's affecting every age group, from our children to our teens to our seniors and everyone in between. And I really wanted you on the show to help us dive into this topic because I think that we hear a lot of chatter, but we don't really understand what's going on. So I would love to learn more about the work you're doing and how you entered this field of mental health, anxiety and depression, and, you know, what your perspective is on what everyone's going through.
Well, I mean, I entered this field because honestly, there was a need for this, and this field of psychiatry rescued me. I used to be an anesthesiology resident, and I remember being in the OR, the operating room, and thinking, like, is this really what I'm supposed to do with my life? And feeling so empty and experiencing anhedonia, which is something that a lot of people in medical cultures know about, but
Right.
a lot of people in regular culture have never heard of it. They're like, anho, what? But anhedonia is this feeling of meh, blah, lack of interest.
Not happy, not excited. Yeah.
Just really blunted. And I was having that. And the funny thing is that I knew what it was. I'd heard of it, studied it, and it snuck up on me. I didn't even realize I was experiencing it. And when I realized that I felt so empty, I was like, I have to make a change.
And this
I have
is
to
while
shift.
you're in residency, or you're already
Residency.
out working and stuff like that?
I was in residency. Yeah,
Okay.
I was a resident, which is basically a doctor in training
Right.
in anesthesiology. And it is a very important field. I have a lot of friends in it. But, you know, if it's not the right fit for you, you can feel very empty doing something like that.
You know, before we move into mental health, you've brought something up that's really important. I have been in medicine for probably over 25 years. I'm dating myself. But one of the things that I've observed is that anhedonia amongst our colleagues. And that can sometimes turn into despair, and it can actually turn into addictive behaviors, destructive behaviors as time goes on. And I think the bravery to be mid-path in a profession where you follow a road, you get things done, you keep going, but the bravery to be able to stop for a second and switch is something I want you to talk about for just a second, because this show is not only, for patients, but it's really for our physician community too, right? Because as we're trying to change medicine, we want to change it for the doctor too, because the doctor is just as burnt out, just as frustrated, just as empty as many of the patients that they're serving. So talk to us a little bit about what made you feel that way as you're going through your training, and what really gave you the courage to make a switch.
The healers are not healed. They're just not
Love
healed.
that. Yeah.
But the culture of medicine, and this is not just doctors, it's healthcare providers, healthcare professionals. The culture is such that if you slow down, if you admit that things aren't okay, you're shamed.
Yeah.
You're letting the team down. It's almost like the military.
It's like the military. Right? I just told my daughter that the other day. I'm like, going into medicine, she's 16. She was like, I like medicine, but I don't know about the journey. I'm like, going to medicine is like the military. They break you down. And if you care about people enough, you can maybe make it through, but it's a really rough journey. It
is. And if you say the wrong thing, if you appear to be complaining, then you're seen as, well, you're not a part of us. You're letting the team down. Like, I went through it. Shouldn't you go through it?
Right.
So there is this kind of element of hazing involved. And also, if you do ask for help, if you're brave enough to ask for help, sometimes you're told that you have to report your mental health condition to a board. So then imagine being a medical student, accruing all this debt, basically delaying happiness and pushing off youth, and then being told that when you do break down, you may not be able to work.
Right.
I mean, it's
on your record.
It's on your record.
Yeah.
It's your worst nightmare, because you now, are from a position of relative scarcity.
Yeah.
You have all this loan, all these debts. So you're kind of pushed between a rock and a hard place. You can't ask for help, even though you know you need it. And a lot of people are struggling. So I was one of the brave folks.
You were. I'm so proud of you.
Who at the time I was just like, I cannot do this anymore. And I left that field, and psychiatry was the residency that I entered. And I entered psychiatry because a girlfriend of mine was like, this is great, Judith. You would love this. You did this rotation as a medical student in South Africa, and you were doing these trauma-focused groups with these orphans, and you came back glowing. Like, this is your calling. But I'm from a Caribbean traditional family where the real doctor has the scrubs, is in the operating room, has the whole getup. So when I told my family, I was like, I think I'm going to become a psychiatrist. They were like, what? They're like... And my parents are Caribbean, so they were like, you're going to go and work with crazy people? What's wrong with you? And I was just
I love that.
They're not crazy. But entering Columbia residency, we all had the opportunity to start our own therapy. So I had never been in therapy. And when it was offered to me, I was just like, well, I don't need that. Even I had stigma, right? I was like, that's for like really severely mentally ill people.
Right.
But boy, was I wrong. Starting therapy as a resident changed my life.
Wow.
I mean,
In what
I
ways?
thought I didn't have trauma. I was like, that's for other people. I unpacked traumas that I wasn't even aware of, right? It changed my life. It changed the way that I think about people. It changes the way that I interact with others. I became aware of my attachment style. Not everyone has a mental health diagnosis. Not everyone has a DSM-5 condition, but we all have attachment styles.
Yeah.
We all have emotional traumas. We may not have a trauma that the DSM-5 designates as a trauma, but we all have emotional experiences, painful psychological experiences that shape us and changes the way that we view ourselves in the world and the way that we interact in the world.
And our decision making, right? DSM-5, by the way, guys, is the way that we diagnose different mental health conditions, different categories, just to clarify that for just a second.
The Bible of psychiatry.
The Bible, that's a great way to, and it gets updated periodically,
It does,
right?
yes.
So, so you're in therapy, you're unpacking your own traumas, which you were unaware of. What is that? Is that talking? Is that just for somebody watching? Is therapy always talking? Is it always talking and going through? How do you get to that point of walking in, not thinking you need it, and then going down a road of like, wow, that's what I'm doing and that's the way I'm behaving?
Well, there are different types of therapies, just like there are different types of treatments in other medical fields, right? But the type of therapy that residents, at least in our residency, what we were offered was a psychoanalytic psychotherapy, which is a very deep, introspective type of therapy where you're working closely with the therapist and you're kind of playing out themes in life, like attachment themes and so forth. But there are different types of therapy. There's dialectical behavioral therapy that's focused on emotional regulation, distress tolerance, interpersonal skills. There's cognitive behavioral therapy, which is a behavioral therapy that's very helpful with anxiety, depression, sleep. There's more like parent-child type of therapy. So you have many different types, somatic therapies. But the type that I was in focused on my, early experiences, my attachment. And my therapist, and I talk about this in my book, High Functioning. My therapist said, I think you're masochistic. And I was like, but wait a second. That was taken out of the DSM-4. It was in the DSM-3, the Bible of Psychiatry, but they removed it from the 4. So how could it be something that's not in there? And a little secret, us therapists, we use terms sometimes between ourselves. But, technically masochism was removed because it's something that people thought was victim shaming.
Right.
So a masochistic individual will put others first, will sometimes bend over backwards, even though they themselves are not, happy. It's actually hurting themselves. Sound like medicine, right?
Yeah. Self-abuse.
Right?
Yes.
We're told to put the patient first.
Right.
We suffer. Doctors work long hours. In surgeries, you're holding your urine for hours.
Yep.
You're not eating. You're putting the patient first, but this is noble. There are a lot of masochistic people in medicine, but we're not allowed to say that, right? So
why does masochism have such a negative connotation then? I think instantly like selfish and all these other words come to mind when I hear that term.
Well, because traditionally, medicine has a lot of things. Psychiatry has problems from the past, right? So, traditionally, masochistic patients were seen as women who were in abusive relationships, who kind of provoked people to, hit them, right? So there was a connotation with that, so like the abusive side. But there are elements of masochism that still apply, right? You don't have to use those type of inciting violence traits. But what we call masochism today, the acceptable form, is people pleasing. How many memes have you seen about people pleasing?
A million. People pleasers are us. Call now. There's that one that I see all the time. But
and we laugh about it, but women are still the primary people pleasers.
Yes.
We put our children first. We have to put on the facade of we're a career mom. We take care of the elderly parents. We're the ones who are dependable. How many business owners do I know who've been like, I like to hire women because they show up.
Yeah.
But it's really code for they're people pleasers. They go above and beyond and they don't complain. But that has repercussions. Women have twice the risk of depression, twice the risk of anxiety, make up 80% of those with autoimmune conditions. Think about that. It's not all hormones. There's a cultural and societal element to it. We are literally driving down our health and our mental health because of people pleasing.
Wow. And so you discovered this about yourself. What sort of enabled you personally to be able to then make a change? Was it sort of like, wow, this is who I am and what's my next step? Because I'm just thinking about somebody watching or listening who might be in the same boat. They're like, I do spend the majority of my time making sure everybody else is okay, which again, a lot of women are doing over and over again. How do they, maybe it's through therapy, but how do they get to that next step?
In my own work with my therapist, I wish I could say that therapy healed me. But the reality is that when you have a pervasive pattern in your personality style, the work takes time,
it's not like snap my fingers and it's okay.
It's not. And you're going to go through places in life and times in life and frames in life where you're actually doing good work, right? You're constantly self-reflecting. You're saying, I'm going to stop these habits. I'm going to, really make a change. But then you'll fall back into old patterns and that's okay. Personally speaking for myself, I find myself in these patterns. And in my book, I talk about the things that I use, the tools that I use to keep in check. So, I talk about the 5 V's to thriving. Number 1 is validation. I have to constantly self-validate and make sure that I'm acknowledging my feelings, because people pleasers and people who have masochistic traits, they will many times push down how they feel. They won't take the time to acknowledge how they feel because they're thinking about everyone else. And it sounds very simple, but self-acknowledgement and validating your feelings, it really is difficult when you're not accustomed to doing so.
And this is just a conversation with yourself, right? Now we've seen the other memes too. Like, can we talk about my feelings right now? You're not validating my feelings. We've seen that too. But you're starting just with you, the individual, and recognizing and acknowledging how you feel.
Absolutely. And in my book, I talk about all the different ways that people get validation. So it could be external. You can get it through your therapist. I talk about how I use assessments in my clinical practice, how sometimes showing someone a score, a trauma score, is validating in itself. Because many times in mental health, it's not like we can take a blood test and say, oh, look, this is the level of your trauma. We don't have that yet.
Right.
But we do have clinical assessments like the CAPS-5, which is the gold standard for trauma. And if I show someone a CAPS-5 that's really high, it's like, wow, like I was not acknowledging my trauma all this time. Had I known I was walking around with a CAPS-5 that high, I would have been kinder to myself. So there are many different ways to validate.
Assess that.
Correct.
So let's talk about the CAPS-5 for just, are there others too in addition to the CAPS-5? I think there's another one that I'm blanking on the name of that I've seen too.
In my clinical practice, the ones that I typically use are the gold standard. So for depression, I use the MADRS, the HAM-D. But for my own personal research, I've developed my own trauma inventories because many of the trauma inventories focus on childhood traumas, which are really important, like the ACEs, which you're probably familiar with.
That's what I was thinking of, yes, the ACE.
And there's two versions of the ACE that is familiar. So there's like the one that was the original that the CDC Kaiser Permanente had. And then there's the Philadelphia modified one that's based on a more like, I think, comprehensive experience. So it includes more urban environments, but they mostly focus on childhood events. And the reason they focus on the childhood trauma is because your brain is thought to fully develop when you're 25. But we know that just because it's mostly developed doesn't mean that it is static. So it changes. There's neuroplasticity. So in my trauma inventory, I included a lot of adult experiences, such as divorce.
Yes.
That's traumatizing.
Yes.
Bankruptcy.
Traumatizing. Business loss.
I mean, seeing a loved one in the ICU, traumatizing. But in the classic sense of the DSM, the Bible of Psychiatry, a trauma is something that's life-threatening or an assault or combat. So something like being, in the hospital for a prolonged COVID-19 wouldn't count.
Right.
But try, like when I have a patient in front of me telling me that that's traumatizing, and I have to tell them that doesn't meet criteria for this study.
Right.
It's so invalidating. So I go off the record. I'm like, for this study, it's not trauma, but between you and me, it's trauma. You may not meet criteria for this one, but I believe you. And that for someone is so powerful. That validation is so powerful. There's something called affect labeling in psychiatry. If you name a feeling, that decreases the anxiety tremendously. It is therapeutic to name a feeling. I mean, that gives me goosebumps every time because many people walk around, they don't know how they feel. They don't know why things aren't going well for them. And if you can name it, it's not only validating, but it is therapeutic because it decreases the stress of the unknown, and human beings cannot handle uncertainty. It is terrifying. That's why we're like, take the Band-Aid off. Let's just pull it off. We just would rather know. So naming the feeling is very powerful.
So self-validation, and we could spend an hour on self-validation, honestly, but I just think it's so important because so many people walk around with, including us, walk around with blinders on, and it took a lot of stumbling and bumbling around to figure out that that's what was happening, right? Can somebody on their own, we, by the way, have mentioned the ACE, we've mentioned the CAP-5, you have your own trauma inventory. I know you have a book coming out right in April. Does it have the trauma inventory in it?
Yes.
Because I think that, would you recommend all of us to be doing assessments like this on ourselves in some fashion? Maybe we do it every 6 months or so, or once a year, just to see where we are.
I went into this field because there's a shortage of psychiatrists, a shortage of therapists. In some parts of the United States, there's one of me for 30,000 people.
Wow.
I can barely handle 30 people.
So
in the midst of a mental health crisis. Imagine that.
Yeah.
And as a researcher, I have my own lab. I find, again, these quantitative mathematical ways of showing someone this is what you're experiencing.
Mm-hmm.
This is the number of your trauma. And after the treatment, let's see if that number goes down, right? Or after the treatment, let's see if that number goes up. Maybe we're worsening things.
Right.
I find it so powerful to have a number. And because there's a shortage, no, I'm not encouraging self-diagnoses, but I am encouraging people to learn about their symptoms and to have some type of metric for understanding how severe they are. So that's why I created these scales, to democratize mental health, because there's just not enough mental health providers out there
to meet the demand.
To meet that demand.
Wow. All right, let's move from self-validation. You said there were 5 V's.
Mm-hmm.
So tell me about some of the other ones.
So the second V is venting. Okay, now that you know how you're feeling, how do we express it? And I love venting because I studied chemistry and physics. And so venting, if you think about a balloon that's really tense with the air, but once you start letting that air out, and we do this in our lab, the tension goes down. So we got to get it out somehow. Mm-hmm. But not everyone is verbal. Not everyone likes to talk about things. So I wanted to provide people with skills and tools that felt comfortable and authentic for them. So I talk about some of my artists that I work with in my practice. Their venting is through singing. So
yes.
I'll ask them to sing a song or to draw paint something,
right.
or draw a sketch to express how they feel. But for others, I mean, I love to talk. So for me, it's talking with my therapist. Like, that feels good. Or talking with a loved one. My dad's a pastor. For him, it's prayer. He prays every day, sometimes 3 times a day. But he feels better after he prays because he's talking to a higher power that he believes loves and cares about him. So there are different ways to express how you feel. One of the ways that I started using over the past 2.5 years was social media. I was a newbie to social media,
right.
but I started venting over it, and then I grew to almost 1 million followers.
Wow.
I'm like, wow, venting is powerful.
Amazing.
It really is powerful.
Yeah. So validation, venting, these are tools that you yourself used personally.
I use them personally.
In your journey
mm-hmm.
to kind of go into psychiatry. What's that journey like, been in psychiatry?
So, it, like many fields of medicine, psychiatry is very conservative.
Yeah.
But I had to spice it up a bit.
Love it.
There aren't that many Trinidadians in psychiatry.
Spicing up medicine over here.
Put the curry in there.
Yeah, I love it.
And that's why the motto of my lab is the science of your happiness. There is a field called the science of happiness. But to be honest, it is primarily populated by people who don't look like me.
Right.
So I wanted to write a book where people could see themselves. I've traveled to over 30 countries learning about mental health. And the science of your happiness includes your personal experiences, your culture,
mm-hmm.
your beliefs. And so the third V is values. We all have different values. When we come to a country, we think, okay, money is the thing. We got to get that house. We got to get the American dream. But at the end of the day, when we're on our deathbeds, we're not going to be like, I wish I could have gotten a Porsche, right?
Mm-hmm.
You're thinking, I wish I had done things that I really gave me a sense of meaning. I wish I spent more time with the people that I loved, right? I wish I was doing things that gave me purpose. So your values are really those things. And I say it's the things that are priceless, not the things with a price tag.
Mm.
So if you can feed into those values, even a little bit a day, right? For me, it's kindness. So if I can buy my team lunch, great, I feel good. And it's a little selfish, right?
Right.
Or if I can hold the door for someone, feeling connected to others, that's my value. But for someone else, it could be nature.
Yeah.
So, if you can take a walk outside, if you could, instead of taking the train, walk through Central Park, if it's safe, things like that. So really trying to figure out and, and give a platform to things that give you meaning and purpose in life.
So this is important,
mm-hmm.
and it comes home for me a little bit. You're tying together values and culture,
mm-hmm.
values, and obviously both of us have not had the traditional, you can look at us and know we've not had the traditional experience, here in this country. And when I even think about, my childhood home,
mm-hmm.
there was a lot of dysfunction, which was cultural,
mm-hmm.
a lot of cultural dysfunction,
mm-hmm.
A lot of trauma for all 3 of us as sisters in terms of what we experienced and dealt with. When we're dealing with mental health, and it looks different in different packages and different people, and I'm like fascinated by you traveling around the world, so we're gonna have to talk about that too in a minute. How do we help people understand that they can't look at their anxiety and at their depression in a singular fashion?
Mm-hmm.
How do they embrace their culture? How do they embrace sort of the background that they were raised in, you know, to then put a context to their anxiety, depression, whatever their the mental health story is?
And that's why I use the science of your happiness.
Your happiness.
Your happiness. When I go on talks, when I travel, I always say mental health is not someone else's, it's yours. And that is very powerful. Recently, I gave a talk to people who are from the Caribbean diaspora.
Yeah.
And I said, you know, when you're whining, because we move side to side in our dance, when you're whining, you know what that is? It's bilateral stimulation. It is your left and right brain communicating, talking to each other, and you're feeling better. You're feeling less stress. And bilateral stimulation is something you'll see taught at Harvard, right? The tapping.
Yeah, we talk about tapping all the time.
EMDR,
right?
you know. But did you realize that you whine side to side? That was your way of practicing bilateral stimulation. And they're just like, oh, wow. And I'm like, yeah, it's healing. That's why you feel so good when you whine.
I love that.
And I said to them, you know, like the curries that you eat, the pepper sauce, that's anti-inflammatory. So you didn't even realize that you were eating
healing
food
yourself.
That makes your brain feel better. That makes your joints feel better. And in my book, I talk about all the different cultures. I've been to Israel. I've been to the Middle East. I've traveled to Asia. There's elements in your culture that you did not realize was mental health. You just called it something different. So don't be deterred by it. Don't say, oh, it's not me. Like, I don't have those problems.
Yeah.
Mental health is yours. You just forgot about it. And I think when people can take that ownership
Right.
and they reclaim it, it feels authentic. They want to nurture it. Everyone has mental health. We may not all have a mental health condition, but we all have mental health the way that we have physical health.
Yeah.
And we have to nurture it. We have to take care of it so that we don't develop a mental health condition.
Do you think that we can't complete our individual mental health stories until we accept the cultures from which we came?
I think it's very difficult to reconcile, you know, if your past, right? It's difficult to reconcile your problems in the present if you're not acknowledging your past. And I do think that it just allows us to take more ownership when we think about the way that our past culture, our cultural groups impacts our present thinking. Many of us want to run from it. We want to assimilate.
That's
we
where I
want
was
to be like
going with
everyone
this.
else.
Yeah, that's exactly where I was going with this. I think that the story for many of us that are, I guess, what are we, first generation, second generation, whatever we are, you know, is the initial story. And actually, I look at my daughter too. I think the story is we want to assimilate.
Yeah.
We don't want to accept that we were A, B, C, or D, right? And in that running from, I think we run from ourselves. And at some level, I think we create more anxiety and more angst almost, you know. So that's why I asked that question. I don't know what you've observed and seen in your travels, like when you're going to all these different countries, whether it's Israel. I don't know if you've been to other areas of the Middle East yet or not. I'm so curious to know what you saw there. You know, what are you seeing in terms of how those communities heal themselves? And then how individually, many of these communities around the world are family centric. It's not about the individual. So how does the individual survive in those constructs, in a mental health construct? Because my, you know, again, limited observation has been that in a lot of these units, it's ignored, you know, or dismissed.
You know, a lot of the cultures that I've interacted with will say that, well, it's not about the individual. It's about the family.
Right. Yeah.
And so don't shame us, right? And how dare you be selfish and try to create boundaries.
Right.
that doesn't exist.
Exactly. It's a boundary.
You know, it's really difficult when you're trying to have one step in one culture and then trying to assimilate. And so it is more challenging when you're in a different country. But what I've noticed when I've traveled is that people tend to find ways to separate themselves from others as well. So like I was in China and the main cultural group was separating themselves from subcultures. So they're even within a larger country,
culture.
There are still separations. But what I do find is that if you can bring it back to the goal, right? What is the goal for everyone? We are in the same boat. You know, even if, let's say, a parent doesn't agree with a child, you know, younger generation, just think about what the real goal is. The goal is for you all to be happy, to be together, to be to experience abundance. So you're really not fighting against each other. You may have differing ideas, different perspectives, but you still have the same goal. And I find that very simple message, that simple theme tends to unify people.
Mm-hmm.
But often I see this recurring theme, no matter where I travel, that people within certain cultures forget that they have the same goal.
That happens all the time, and that creates conflict.
It does. It creates conflict. So one person may agree that mental health is important. We should take care of it. We should see a therapist. And the other person's like, no, that's not part of our culture. But when you bring it back to the goal, like you all want to be healthy, you want to be together, you want to be unified, you really want the same things. You're just looking at it differently.
I love approaching the family unit that way. Like we all are on the same mission. We have the same purpose. So values, venting, validation.
And vitals.
Vitals. We know that word. What does it mean for you?
So of course it's like the typical boring doctor stuff, like
pulse,
eat
heart
well,
rate, blood pressure, all that stuff. So.
Eat well, but really eat foods that nurture your brain. There's a whole field of nutritional psychiatry now that shows that certain brain foods can be so powerful, and in some studies can be very effective, even as effective as certain medications. So leafy greens, omega-3 fatty acids, all are brain healthy. You know these things. Eating things that are not processed, because that increases inflammation. And then getting movement in. So, not necessarily going to a gym, but like getting some dancing in every day, walking, steps instead of elevators. And then looking at things like sleep. So sleep is restorative. We all need sleep. Making sure that you practice good sleep hygiene, that you have good boundaries in the bedroom with regards to not taking work into the bedroom, work-life balance.
Yes.
And then your relationship with technology. This is something that
a big one.
A lot of doctors aren't asking about, but I think it's going to be a big deal. I think that the Bible of Psychiatry, the DSM, will eventually include a whole set of disorders related to tech, because technology impacts us and it's relatively new in terms of human history, right? And then relationships. Your doctors don't necessarily ask about your relationships, but in longevity science, we know that the quality of relationships, that's the primary factor in terms of your outcome, in terms of your longevity.
Wow.
So if you have negative, toxic relationships, then that's draining your life source. If you have positive relationships, that can actually extend your life. So all of these things are vitals. I call it my new vitals.
I like it. So relationships. So these are personal relationships. What about career or professional relationships?
The same.
Equal value?
Perhaps not equal, but very important. Think about where you spend the most time.
Right.
If you're spending more time with your boss, then maybe that is the most important relationship in your life. Because if that relationship is toxic, that's draining your life source. I teach my patients, and then in my book, I teach people how to write a biopsychosocial model. And if you're social, so bio is your biology, like your genetics, your chronic conditions, the medications you take. The psychology bucket is, your past trauma, your resiliency factors, your IQ, your attachment style, your past psych history. Social is basically everything in the environment. So what you eat, how you move, and so forth, but also your relationships. So if you're spending the majority of your time with a boss that's toxic, that belittles you, that praises you, that you don't know what's going to happen, that's dysregulating your physiology. That's wearing on your heart. That's breaking down your longevity. So if that's the person you're spending the most time with and they're not healthy for you, you got to reconsider that. I could tell you to eat as much kale as you want.
And it's not going to make up
for that. But if
that
person is toxic and draining your life source, that's the real problem, right? So I include that in the vitals because unfortunately, in modern medicine, we only have like 15 minutes to talk to patients sometimes as healthcare providers. So
how do you feel about that? I don't feel like we can do this medicine in 15 minutes.
I absolutely cannot do that.
Yeah.
So, I mean, most psychiatrists don't have that model, but I think a lot of general practitioners do.
Right.
And they're in a bunch. They're really stuck between a rock and a hard place that we talked about. They're burnt out and they want to do better.
Yeah.
But they really have so many constraints. That's why it's important to democratize this information so people know what to look for, so they can edify their own lives, because 15 minutes is just not enough. But Doctors aren't asking you about that. They're not saying, okay, are you taking your blood pressure medicine and is your boyfriend toxic? They're not doing that.
That's right.
They have to
Dump
prioritize.
the boyfriend. It's on a prescription right here. Go home and show it to him.
It's the rule of twos, right?
Right.
Medicine doctors know that. They only
Right.
they only have a time for 15 minutes to prioritize one or two things.
Right.
Everything else, you're on your own, right?
Definitely. So relationships obviously are impacting your overall mental health. Where does that fit into the 5 V's? Is it a part of the
That's
vitals?
part of the vitals,
Part of
yeah.
the vitals. Okay. And so there's one more V
Yes,
that I think
vision.
I missed. Vision.
Yeah, people who are high functioning tend to be on to the next. They finish one goal and they're on to the next. But they very rarely plan joy. They don't schedule it. They don't celebrate their wins. And that is a problem. And it doesn't have to be a big win. You know, it doesn't have to be like, oh, I got a promotion or I got this award. A small win is getting your kid to school on time. You know, when I get my daughter to school on time, I'm like,
yes,
I'm going to sit and enjoy this coffee. And that's my little celebration. I'm
Right.
like giving myself praise that I did it. You know, it sounds like trite, but it's not. You know, like celebrate your small wins. If you called a friend who was down and you made time for that friend, that's a win. Celebrate it, you know? And the big ones are important as well. Right. I have so many students that I've treated along the years who skipped graduation ceremonies, who skipped certificates. I'm like, so you worked hard for that. Go to that ceremony. You know, if people name you as employee of the week, celebrate it. Talk
a big
about
deal.
it. It's a big deal. Yeah. If you were able to set boundaries with your mother-in-law, that is a huge win.
Right.
Celebrate that one.
Absolutely. Celebrate that one. Well, here you are now entering the field of psychiatry. You've switched from anesthesia. You know, what do you have to say about psychiatry as it's practiced today? I know you're innovating. You've come up with the 5 V's. You have your own trauma inventory. You're innovating the field, and we need innovators like you. But what's happening within the field of psychiatry? Because I know from a patient perspective, and even maybe a little bit from a colleague perspective, there's a lot of frustration and a lot of trepidation with going to a psychiatrist today because medication and pharmaceutical management seem to be the only tools offered. Talk to us a little bit about that.
So I'm in this New York City bubble where I don't know very many psychiatrists who just do medication.
Right.
It's mostly therapists, but I would imagine that the majority of the country is not like that.
Right.
People, again, there's a shortage. So a lot of psychiatrists are not able to do that. They're asking their patients to be in a therapy with a therapist who could be a psychologist or a licensed social worker, because that's the majority of the therapists now, just because it's just a shorter amount of training and more accessible to become that, and less student loans and so forth. But in with the psychiatrists that I know, they're very holistic. So they are learning about things like menopause and hormones and diets, you know, and nutritional psychiatry and movement and lifestyle. And yes, it's not possible to find a psychiatrist like that the majority of the time, but you can have a comprehensive treatment plan with a therapist and a psychiatrist.
Building a team,
yes.
That's collaborative.
And a general practitioner too, because you do need labs done every now and then if you're on certain medications.
Yeah.
So you are also a part of the treatment team. Don't think that I have like 1, 2, 3 specialists and that's it. You're the glue that holds that team together. So be active, be an active participant in that team. Take, notes about how you're feeling. I ask my patients to log, basically what they eat during the day, how much caffeine they're consuming, who they're interacting with, and take these quizzes, right? So that you can see, on this day, my depression score was higher, meaning higher, as in not a good thing.
Right.
What happened that day? Did I get sleep the night before? Did I have too much caffeine? Did I interact with a toxic individual? So really become your own historian. Be the best historian. Be the best part of the treatment team that you can be, because you are really the glue that holds it together.
I love that. Do you think within the field of psychiatry, there's more research being done on some of the effects of food in mental health, technology in mental health, relationships and hormones and mental health? What does the research world look like? Because I know you've got your hand on that. So tell me a little bit about what you're seeing.
There is a lot more research. There's a whole burgeoning field of nutritional psychiatry. It's changed my life. When I started learning about the foods that you can eat to depression, to beat inflammation, I changed my whole diet. Like it was radical. I'm high functioning AF, so of course I did it all at once. But I cut out, sugary foods. I used to love the sugar in my coffee. Now I wouldn't even think about it. I mean, my guilty pleasure, which is kind of gross, is like red candies, but the red dye is so bad.
Oh, what did I used to like? I used to like cherry sours. Do you remember those?
Oh, yes.
I was addicted to cherry sours. Obviously not anymore, but yes.
There are a lot of TikToks on sour candies helping you with like mindfulness and so forth. But mine was red Skittles.
Red Skittles.
Red and purple.
Yep.
But I cut out a lot of processed food. If I can't pronounce it, I will not eat it, which is really difficult to do. So do it slowly. But I found that eating better made me think clearer. I was less irritable. I got better sleep. I just felt better. So it was just like a no-brainer for me. But I understand that not everyone has that, in them.
Right.
Start small, like say I'm going to get more protein. I'm going to get more fiber. Pick one meal or one snack of the day to do right.
Do you think it's more important, and I get asked this in the exam room, that's why I'm asking you, do you think it's more important to prioritize clean food, less processed food, dye-free foods, or focus more on protein, fiber, that type of thing? Like
it depends. If you're a woman in midlife, protein and fiber, like all the way. But for my patients with depression and anxiety, I'm like, no processed, like try to limit the processed food, do clean foods, sometimes it's cheaper to eat foods that don't have all of the, processed stuff in it.
Yeah.
But it depends. But I really, for the women in midlife that I work with, I try to
protein and fiber.
Yeah. Get your
and
vitamins.
then, well, now that let me back up. Now that we're thinking about different segments of the population, I really want to dial into a couple of different things. What's happening with our children? Why are we seeing an escalation of mental health issues among children? And then when we look at teens, it's rampant. Tell me what's going on there.
So, it's no surprise that 2020 was traumatizing. And a lot of our kids have not recovered from that. They're experiencing delays in math. They are experiencing social anxiety, that whole removal from society for a while set them back. And we have to validate that. Let's not just say, oh, like get over it.
Right.
It happened to them.
Right.
And they were vulnerable during that time. Also, the way that they interact now is on screens. And we're learning about how devices impact the developing brain, that it's not positive. Yes, there are positive of social media. You can connect more. You find people that look like you. You can use it to learn. However, this constant exposure, that's unregulated. When you have parents who are working like 9 to 7 jobs, that's a reality these days. That the iPad, that, the phone, that's a babysitter.
Yeah.
We have to acknowledge that. So is there a quick fix? No, but many people, if they do this as a community, if they say to each other, like, we're going to try our best to not have our kids on these phones, that we wait until they're 13, it's called Wait Until 8th as an organization, that maybe that's a fix, but that's very difficult to do. It's very difficult to do if you don't have the resources, if you don't have supports, right? Who's going to watch the kids? Who's going to entertain them?
Right.
But yes, social media has impacted their brains. Being on screens all day has impacted their brains. They're not connecting with each other. They're feeling lonelier more than ever. They have these delays in education. I think this is the recipe for disaster. And not to mention corporate greed. Like parents are working hard and they're not making much. So you're not having your attachment figures present. They're stressed. So it's impacting the most vulnerable, which are the kids.
What's the antidote? How do we turn this around? Are there things that we can do within the home or within our schools that might start to make an impact on this?
Most child psychiatrists will tell you it has to be done in the schools, because by the time you wait for home, it's too late. Like the parents are tired.
Yeah.
They don't have time for that. And also, who has access to a therapist after school?
Right.
So a lot of the interventions are in the schools. So what some of the schools are doing is that they're teaching mental health education. This wasn't a thing when I was growing up.
Right.
We learned sex ed.
Yeah.
But now schools are bringing in mental health education. So this is, How do you know the signs that you're having depression? How do you know the signs that you're suicidal? How do you know signs of anxiety? They're even talking about neurodivergence. So kids are learning about ADHD. And then they're taking it a step further and they're teaching children distress tolerance and skills in schools and meditation and mindfulness. And some schools are like just rock stars and they're teaching children about toxic relationships. I'm like, this is great.
Amazing. I wish I had learned that.
Same. They need to learn about love.
Saved me about a decade.
Yes.
But anyhow.
Why are we waiting until you're already married to be in couples counseling? You should be learning about love early on before you start falling into these patterns. So
such a good point.
I really do believe it belongs in the schools, not for the teachers, because the educators are already burdened.
Right.
And it's not fair to have them now teach about something that they're not even skilled in. Right. So I do think that schools that are doing it well have a separate department focused on emotional well-being, mental health education, and skills training. And when children are learning this, they're able to grow in ways that are more adaptive. They're able to cope in ways that are more adaptive. They're not turning to substances to medicate. They're not turning to their phones. And schools that are removing phones from the classroom, from the school campus, they're seeing improved mental health. They're seeing improved education.
Our schools are doing that. Both my children, my teenagers. You mentioned something that I don't want to leave on the table, the attachment style of the parent when they come home from work, or even maybe they're not working, they're working in the home. Talk a little bit about that and mental health for the family unit, right? Talk to us about that for a second.
If a parent is not healthy, chances are the children won't be. I mean, it is no secret of mental health. When we treat families, we focus on the parents too. Because if a parent is coping better, if a parent is not depressed, if a parent is not stressed, the children see that. Children look to their attachment figures for guidance. So if you're looking at an attachment figure who's not present, that's neglect. Or if you're looking at an attachment figure that's emotionally dysregulated, you're learning those coping skills there. So we really want the parents to learn as well, at least when you're in a therapy setting.
Right.
So the treatment is not just the child. A lot of the work is done with the parent. And the hope is that in schools, when you're teaching children emotional regulation and distress tolerance, that some of that education is going back to the home as well. Usually the parents know what's happening. Hopefully they know what's happening, and that they get some type of curriculum. But we really want to focus on parental health. We don't want to burden parents with having to now take care of the child's mental health.
Is there something we as parents can do within our homes to foster mental health? Is it spending time? You mentioned being present. I think, I kind of can look at the mirror and look at myself and be like, am I really doing a good job at that, as busy as I am? Are there certain rituals, practices that we can develop, within the structure of our family units, to establish that? And then one more follow-up question to that. Is there a tool families can use to screen the health of a family, not just the individual, but the health of a family?
Well, within my home, we practice the 5 V's.
I love
we
the
validate.
5 V's.
We acknowledge how we feel. My daughter's very good at that. If I'm trying to be Miss Busybody, high functioning, she'll be like, "Mom, slow down. I'm tired." And I'm like, "I'm tired too." Maybe we shouldn't do that activity. And I'm like, why was I doing that?
Right.
So, that's the unit checking me, right?
Yeah.
We vent, we talk about our feelings, values. We really pour our energy and our time and our resources into things that we value. Family. We value family. So my daughter will spend a lot of time with her cousins because she values it. I value it. Vitals, getting good sleep, falling asleep at the right time, waking up at the same time. My daughter, great diet. She eats a lot of veggies. I'm lucky I have one of those kids that doesn't like,
Might be an anomaly.
She is an anomaly.
Yeah.
But we get good movement in. If I'm doing my exercises, she's doing them with me.
Yeah.
We practice.
You're modeling it.
Yeah. Right. She's not allowed to have an iPad. She doesn't have, the only screen she gets is a television. She gets a set time. So I'm really trying to do these things for her. And she'll tell me, "Mom, you've been on your phone." And I'm like, "Oh my gosh, I got to put it away," right? She keeps me in check.
Yeah.
So in Vision, we plan joy. We have a calendar on our refrigerator with the big things that we want to celebrate and the little things that we celebrate, right? So I think the 5 V's, every family can do it. They're free. I want to democratize mental health. And you don't have to do all of them at once. You pick 1 or 2. The rule of 2 is right. 1 or 2 that you think you really need to focus on. So if it's values, if you feel like your kids are just like over like valuing materialistic things, then let's figure out how to bring them back to what our family culture values. If it's volunteering, maybe we'll do something like that once a month, right? Or if you feel like the vitals isn't a place where you're strong, then maybe setting better boundaries around your taking care of your body.
So picking
and brain.
like a category and just parking there and spending some time on that as a family unit.
Yes.
Can probably reset the cadence for everybody there.
Absolutely. If communication is not great in the home, then maybe focusing on venting and saying at least one day a week we're gonna have a dinner together and talk about, what we're experiencing, validating how we're feeling and venting it, right? That could be the thing. And people don't know this, but the number one predictor of whether or not young girls don't, commit suicide is having like family dinners. Family dinners and team sports. Why? There's open communication, right? There's validation happening in team sports. Same thing with family dinners.
Right.
There's open communication and validation. If families knew that, they would do that more. You don't have to go out and spend a lot on a fancy therapist.
Right.
Some cases you do. But, for the majority, just sitting and talking sometimes, talking about how you feel openly and honestly and validating each other. It's so powerful. But if we are on our screens and if we're not making time, right? If the system is oppressing and not allowing us to spend time with each other, we're not going to be able to do that.
Yeah. Oh my gosh. There's so much more we could get into. This is such an important topic, and I know we're pushing up against time here. I do want everyone to get a sense, and I actually want to know too. Tell us a little bit about your lab, the research you're doing. Tell us a little bit about what people can find in this book that's coming out on my birthday, by the way, guys. I love that. So just connect us with kind of what's happening in your world.
Well, my lab is studying high-functioning depression, and it's not a term that's recognized by the Bible of Psychiatry, DSM, but it is something that I found people are struggling with. The strong ones, the mom who's taking care of everyone but herself.
Ones, right?
The successful ones.
Yep.
The teacher who's taking care of her students and not eating lunch. The doctor who will work through a surgery and not go to the bathroom. The strong ones who don't acknowledge their emotions, who wear that mask of productivity. No one knows they're struggling. No one knows. I wanted something for them because in the DSM, the Bible of Psychiatry, you have to check a box saying you're decreased in functioning or you're in distress. But what about people who have these symptoms, but they're still going? They're overachieving. They're overfunctioning.
Right.
They don't slow down because they can't. People depend on them. What about them? There's nothing for them.
Yeah.
Absolutely nothing for them. So I wanted to make a book that spoke to the strong one who actually is struggling. And, it's something that, if you're someone who's high functioning in your life and they don't talk about their feelings, the book will speak for you.
And I think there's a lot of stigma too for the strong ones, right? Like, I don't need that. I don't need a therapist. I don't need, I'm fine. I got this. I'm going to power through. So I think this is a great way to maybe start to open up those conversations so that people can use the 5 V's and apply it to themselves and to their family unit as well.
Absolutely.
I think that's incredible.
Or the person who's culturally can't talk about how they feel, like the student who's an immigrant who's like, they're the first person to have the opportunity, so they can't complain because those before them didn't have that opportunity, right? So it's for people who are not traditionally acknowledging how they're feeling, and these are simple ways for them to feel full and fed, to feel whole, to beat anhedonia, right? To process their trauma.
Anhedonia is an important word. I hope everybody heard that today. I think many people walk around in that state and assume that that's just the way things should be. And they sometimes blame midlife. They sometimes blame a partner, a job, a boss. But really, it needs a little bit more inner work. Well, this has been amazing. I've got to ask you one last question before I let you go. What makes you whole?
What makes me whole is connection with others. I'm from a family of four kids.
4 kids. I love it.
I grew up in a church, so I had a community, and I know when I'm slipping, when I stop reaching out. So what makes me feel whole is connection with others.
And this is from a woman who is grounded in so much science. And at the end of the day, it's our human experience that needs each other. And I love that. Well, thank you so much for joining me today. I think this is such an important conversation. I hope after this episode, families will sit down at the dinner table and hopefully really take a hard look at where everybody is, in terms of their mental health, so that we can start to chip away at this crisis. Thanks again.
Thank you for having me.
Thank you so much for listening and watching today's episode of Whole Plus. Be sure to share this episode with your friends and family. And if you haven't already, please take a moment to subscribe to this podcast on YouTube or click the follow button on Apple, Spotify, or wherever it is that you get your podcasts. And don't forget to follow me on all social channels at Dr. Taz MD. Until next time, stay healthy and stay whole.